Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health, reporting for the week of September 22nd, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on COVID and respiratory illness and measles status, I will touch on recent developments, both concerning ones and hopeful ones. So first, starting off with an update on respiratory viruses, taking a look at those viruses among patients presenting to a healthcare setting for testing. We can see, if you look all the way over to the right, the last 4 dots or so, and each dot represents a week. So the last month or so, being reported there, you can kind of see that the proportion of tests in a medical setting that are positive for SARS-CoV-2, that's in the red, has been decreasing, while the proportion that is rhinovirus, enterovirus, or the most common cause of the cold is increasing. And all the others like flu and RSV are pretty minimal, as expected for this time of year. So why do we care? So this information is really helpful for those of us trying to keep track of what's going on, but also at the individual level, it's certainly relevant, especially for someone who needs to be treated. So there's no treatment for the common cold, as we know, but when it comes to SARS-CoV-2, we know that early antiviral treatment can prevent severe outcomes. So on the individual patient level, the diagnosis is certainly important for that reason in particular. Taking a look now at SARS-CoV-2 in the wastewater, and this is looking at nationally. In the black, the virus activity for COVID is considered high, and it's highest in the southern region, followed by the west. And remember that whole gray shaded area is preliminary, so hoping that what looks like a downward trend is real and will continue. So we'll continue to keep an eye on that. And this is also taking a look at wastewater, but looking at it on the map by state rather than by those big regions. And the darker the color, the higher the viral activity. So we can see that much of the west and the southeast are high, while quite a bit of the northeast is moderate or low. And this is showing wastewater levels for the week ending September 13th. So let's try to keep this picture in mind as we move to the next map, which is looking at epidemic trends. But here, in terms of wastewater concentrations, we're seeing it highest in the west and much of the southeast. And when we look at epidemic trends, remember this uses modeling based on emergency department visits to see what direction things are heading. And so this almost looks opposite of what we were looking at before. So the west and the southeast are declining. So they've got the highest wastewater activity, but they're also heading down. And then in the northeast, where we saw mostly low and very low wastewater activity, the trend is heading up. So it seems like perhaps maybe the west and south got a little bit of a head start this summer, and hopefully maybe have already reached the peak, and hopefully maybe are on the way down. This remains to be seen. Whereas the northeast has been pretty low so far, but is heading up. So we'll just continue to keep an eye on this. And taking a look at COVID hospitalizations, that's the orange line. And again, the gray shaded area is preliminary, but it does look like things are either leveling off or coming down in terms of hospitalizations. As usual, there's a great variability from state to state regarding hospitalizations. And so you could take a look at the link in the post if you're interested. But looking at this nationally overall, we're typically seeing about 90% of hospitals reporting. So that's pretty good. In the gray shaded area, it's more like 81% right now. So again, as more data gets added, the figure will become more accurate. But hopefully the trend we seem to be seeing here in terms of leveling off or maybe even decreasing is hopefully real and will continue. I mentioned a couple of weeks ago that the CDC page looking at COVID deaths and data in general, but including deaths, is being presented a little bit differently now, including this graph with the deaths on it that has not been updated at all, actually, since I reported last week. So that's a bit unusual, not sure what's going on there. But the good news here is that we have seen under 300 deaths every single week since early May of this year. So these are some hopeful record lows that we've been having. Just for context, during the winter, there were over 1,000 deaths per week at the peak. And so that was in January. And last summer, we peaked at 1,358 deaths the last week of August. So we never know what's going to happen next, but death records in this country are actually one of the most reliable metrics we seem to have. So this does seem to signify progress. And so we don't know what this might mean, having a more reasonable summer wave in terms of severe outcomes. We don't know what this might mean for next winter. Much of it will surely depend on vaccine uptake, but we know that if someone gets COVID over the summer, they are less likely to then get it in the winter and vice versa. So these two waves per year that we seem to be getting do likely impact one another. So something for us to continue monitoring and analyzing as time goes on. And now shifting to take a look at measles, the United States measles situation is certainly continuing. There have been 37 more cases since I reported last week, so we're now at 1,491 cases. In all of 2024, there were 285 cases, and 69% of them were outbreak associated, meaning that over a third were basically imported in. So, but so far this year, we are at 1,491 cases, with 86% of them being outbreak associated. So much more local spread this year. Doing the math, all of last year, there were fewer than 200 cases that were associated with outbreaks, while this year we've got over 1,200 cases that are outbreak associated and counting. So certainly continuing to head in the wrong direction there. And as a reminder, measles is highly contagious. We are especially worried about those who are too young to be vaccinated, others who may not be able to be vaccinated, or those who, for whatever reason, did not mount a response to the vaccine. And it's not just about getting a rash and recovering. As we saw on the prior slide, 12% of cases were hospitalized, and even with the best medical care, it can be fatal. And not only that, but it can wipe out prior immunity, making survivors actually susceptible to a whole host of other infections that they previously had antibodies for. And it can also lead to all kinds of bad outcomes, including neurological issues. There can even be a debilitating and 100% fatal late complication that can happen many years later. And I talked about that in more detail last week. So if you're interested in learning more about subacute sclerosing and encephalitis, check out last week's briefing. And so now, as much as it pains me to do so, I would be remiss in not bringing up the Advisory Committee for Immunization Practices, or the ACIP, the committee that advises CDC regarding vaccination. I would love to be able to ignore these proceedings completely lately, but unfortunately, their decisions do have consequences. In the past, we have come to expect the ACIP to be guided by a rigorous and evidence-based process. It's a process that has served as a gold standard for public health really all over the world for decades. Unfortunately, at this point, that seems to be out the window. It seems that ideology has now been given a seat at the table, all the seats at the table, and it's frankly making a mockery of what was once a respected body. Many of the decisions that have been made by this new committee so far are clearly performative at best. They're not expected to have any positive impact on health. And on the contrary, they are likely served to decrease access, among other things. At their last meeting, they had voted to remove a preservative that's barely ever used, the Nasal, and for which there's no evidence to suggest any issue. And at this most recent meeting, they voted to essentially remove the MMRV vaccine, which is measles, mumps, rubella with varicella. So the irony here is that this is a group that has been vocal about their feelings that there are too many vaccines, and now they just made a decision that actually results in additional injections for children. The ACIP's decision on COVID vaccine is also particularly disturbing and is undoubtedly going to interfere with access. Specifically, the ACIP generally seems to be moving away from actual public health guidance that they're set up to do, and instead shifting the burden onto primary care, which is already completely overburdened. And so this decision at best demonstrates serious disconnect about US healthcare by the people who are supposed to be knowledgeable about it and in charge of it, really. So I don't know if these decision makers are unaware that we have a primary care shortage and that abdicating their role in setting public health recommendations by shifting it to primary care is a bad use of resources all the way around and is only going to result in lower uptake, or maybe that is the entire point. What's even more concerning to me is the lack of a process. So we've become accustomed to the frameworks that the ACIP used to go from evidence to recommendations. And unfortunately, it seems as though no process for moving from evidence to recommendations is in place. Instead, committee members' hunches and ideology are taking center stage, making the entire process basically useless and really an embarrassment. I think the chair of ACIP, Martin Kulldorff, summed it up well when he said at the meeting, "We are rookies." That was a quote. In my view, the committee has done nothing to increase safety or improve health, but they have done a lot to introduce confusion and to decrease trust and to decrease access. So far, everything that they have done is both backwards looking, rehashing settled science with no new evidence, and it's actively taking us backwards. So many of the medical associations have come out expressing their concern. A whole host of experts have provided specific commentary on the concerning path we seem to be on. So rather than dwell on this, I want to spend the rest of our time today looking forward, because the reality is that despite the best efforts of our so-called health leaders, science is marching on, and there are incredible innovations on the horizon, as well as real health leadership emerging in many places. So first, I'm getting a lot of questions about whatever happened with the nasal spray vaccines against COVID-19, and there has actually been some progress. So there have been a few nasal vaccines authorized in other countries over the past few years, like China, India, and Russia, but there hasn't been much in the way of real-world data to see how they are working, nor clinical trials to really look at from abroad. We don't have an FDA-approved version here in the United States. There's nothing approved in Europe either, or Canada, but the science is promising and there has been some forward motion, even though I know it is slower than we would like. So as a reminder, the key here with the nasal spray vaccine is to create kind of a frontline defense in the nasal passages to stop the virus from replicating and transmitting. So this is called mucosal immunity, where an immune response is happening right there in the respiratory lining, and it could even prevent you from getting sick in the first place, in addition to preventing transmission and preventing bad outcomes. Now, we know that there have been so many funding cuts at the federal level, including Project NextGen, which did have a number of different trials included in it. But there were some trials for mucosal vaccines that were already underway that are continuing. And of course, the federal government is not the only funder for this type of research. So even though there is some uncertainty and probably delays compared to what we had previously anticipated, there have been some new developments. So just this past July, a study was published in Science Advances that showed some encouraging results from a phase 1 trial of nasal vaccine candidate called CyanVac. The official study vaccine name is CVXGA. This is the first human clinical trial of a nasal vaccine in the United States. I've linked the article in the post. So this phase 1 trial was in 72 healthy adult and teen participants from 2021 to 2023. And from this trial, they determined that the vaccine was well tolerated without serious adverse events or fever. Side effects were all considered mild. The nasal vaccine did result in antibodies being created, including those mucosal antibodies that we want. And there were significantly lower rates of infection among those who got the high-dose nasal vaccine compared to those receiving a lower dose of the same nasal vaccine. So the phase 1 trial looked at reactogenicity, so were there a lot of side effects, and determined that they were very minimal, so minimal reactogenicity. And it looked at immunogenicity, so did it provoke an immune response? And it did. So it is immunogenic, with minimal reactogenicity. So this is what we want. And so all in all, the results were very promising. So then 2 larger phase 2 clinical studies were initiated. One of them was a randomized placebo-controlled double-blinded study on a larger group of adults to again look at safety and immunogenicity. That trial is complete, which means that the last participant's last visit has occurred. There were a total of 227 participants enrolled in the study. And according to clinicaltrials.gov, the study was completed last October. The results have not yet been published, so this is something we are keeping an eye out for. The second phase 2 trial is currently recruiting participants. So I have linked the clinicaltrials.gov listing in the post, so you can check it out if you're interested. They are looking to enroll up to 10,016 healthy participants. This trial is a double-blind phase 2B trial, and the study design is called an active comparator controlled study, because they're going to be testing it against the Pfizer mRNA vaccine. So this is going to be an interesting and important one because we already have an established effective vaccine against bad outcomes, and they're going to be comparing the nasal spray to it on a number of different outcomes, and I'll go into those more in a moment. They're not just looking at severe outcomes, they're looking at symptoms, they're looking at positive COVID tests, they're even looking at people who test positive for COVID who don't get any symptoms. And then, of course, they are looking at those severe outcomes as well. They are also looking at a whole host of adverse events, all of the side effects. They're looking at quite a lot of laboratory data, including those related to safety, as well as those related to the antibody responses that we are looking for. It's also going to be interesting because, of course, we know that one of these vaccines is a nasal spray and the other one is an intramuscular injection. So in this trial, some people are going to get an intramuscular injected placebo, and some are going to get an intranasal placebo. And according to clinicaltrials.gov, there are 55 different recruitment sites at locations all across the country. So if you're interested, please check that out. The contact information for the study sites is listed there. They are estimating completing the study in June of 2027. So yes, this is still a little ways off, but still promising, and we will continue to keep an eye on the progress. The next development I wanted to talk about was a study published in Science Translational Medicine last month. Here they unveil a new broad spectrum antiviral that could give almost universal immunity against viruses. It would be short-lived, a matter of days, but this is very interesting and promising. So this innovation was inspired actually by a rare human mutation in a gene called the ISG15 gene. So this mutation causes people who have it to be almost completely invulnerable to a wide range of viruses. So they just either don't catch the virus at all, or they get very mild symptoms. So this might seem great, but the reality is that these individuals are kind of in a constant state of immune activation. So this can also cause them to suffer other issues like inflammatory conditions, skin issues, or being susceptible to other infections like with bacteria. So instead of scientists trying to recreate the mutation, what they did was actually carefully design an mRNA therapy that basically delivers instructions to the cells to temporarily produce the antiviral proteins that these individuals make that fight off viral infections without activating the entire immune system in an ongoing way. So the study that was published was an animal study, and they showed that a single dose of this mRNA therapy provided a temporary shield that basically prevented all viral infections and viral replication. They could not find any virus that could penetrate this shield. And so this technology is extremely promising as a potential rapid response tool for public health emergencies. It could potentially be used even maybe as a post-exposure prophylaxis. So imagine someone in your household gets COVID or flu, and then others in the household could take something that would essentially shield them from also getting it. I could also see this being incredibly useful for first responders and healthcare providers, especially if and when we are faced with another viral pandemic. So definitely an interesting innovation to watch. And now moving to our states watch. Last week, we highlighted the West Coast Health Alliance, a proactive group that is led by the governors of California, Oregon, Washington, and Hawaii. And I had also mentioned an alliance that was forming in the Northeast. That group has now formally announced itself as the Northeast Public Health Collaborative. Includes Connecticut, Maryland, Maine, Massachusetts, New Jersey, New York State, New York City, Pennsylvania, Rhode Island. So this collaborative has already formed working groups to address key areas like public health emergency preparedness and response, vaccine recommendations, vaccine purchasing, data collection, data analysis, and more. These alliances, I think, are a truly powerful response to what seems to be the fracturing of federal public health agencies. Seeing the states come together to pool their resources and their expertise, and really to provide residents with a unified science-based guidance is a definite cause for hope. And finally, in a similar vein of emerging health leadership, I wanted to mention a major milestone from our northern neighbor. Canada has announced it is now producing the first made in Canada mRNA COVID-19 vaccines at a new biomanufacturing facility in Quebec. So I see this as a strategic, stabilizing move that benefits the entire region. It's not a direct fix for the US systems issues, but it does provide a layer of supply chain security, improved level of global pandemic preparedness. It's my hope that we'll continue to see more developments like this with health leadership emerging, not just here in the United States, but all around the world. So in the meantime, let's continue to do what we can to stay healthy and to keep ourselves and our loved ones and our community safe. Remember, gathering outdoors is almost always safer than indoors, but even indoors, you can really improve the situation by opening up some windows, improve the ventilation, turn on your HVAC system and or HEPA filtration units within the space. Also use a high quality filtration mask if you're mixing indoors, especially where there's poor ventilation and in crowded high traffic areas. And try to avoid infection and reinfection. We know that there is a cumulative nature to the effects of COVID, as well as increased risk of long COVID, and that risk is with each infection. And if you don't feel well, please test to rule out COVID. Want to do this as soon as possible, as soon as you have any symptoms, and in particularly if you're someone who should be treated for COVID, get treated. There's a small window of time to really reduce that virus replication and prevent going into a more severe case. And if you don't have a primary care provider, please get one. Know how to reach them before you need them. And again, if you're someone who should be treated, then having a treatment plan ahead of time is certainly helpful, because trying to figure it out when you don't feel well is definitely not ideal. And remember to eat a balanced diet and stay well hydrated. Avoid those simple sugars and processed foods. And quit smoking, reduce alcohol consumption. If you don't feel well, please rest and recover. Otherwise, try to get some regular physical activity, get outdoors, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you next Tuesday at 10 a.m.